Hey, welcome back, everyone. Hopefully, you had a chance to catch the business meeting and some of the town hall. Those are always really interesting discussions. And there was quite a lively chat about workforce issues and things, ideas for moving into the future. So, if you listened and had ideas, please feel free to message those or reach out to any of the hosts of the meeting afterwards.
Yeah, I think it was a great session. And just for my own personal, I really appreciated Dr. Fallett's explanation of the APSA Foundation. One of the things that did strike me was just about our membership and the donation percentage, which is only 5% of all members. I am guilty of being in that 95% that has not this past year. But I would just, as I was thinking about it, I would just really encourage everybody to do that. I think if we have 1,000 members, and if people just gave $100, $250, whatever they were financially capable of, we could double or quadruple the amount that's in the APSA Foundation to support like those great research grants that the people receive for the wonderful research that's being done to really move the needle forward. And it's actually pretty simple. Actually, I was looking on it on my phone, and there's this program called Google, and you just type in APSA Foundation, and it pops up, and then you just go to donate now, and then you just scroll through, enter your information. They take all forms of payment, and you just click on 100, 250. If you're getting really crazy, even go higher, and boom, we can all be a contributor to do that. So I would just challenge and encourage everybody who's on this meeting, as well as all the membership, to do that, because I think
Yeah, it's totally true. $100 and for a year, and if you think 1,000
some
members.
extra instant noodles, it'll be okay for this week. So anyways.
Yeah, and I thought that too as well. I mean, I gave a few years back and haven't since. And one thing that Aaron brought up is why not make this a yearly sort of thing? And so sure, I'm part of the 5%, but I thought, box checked, I'm set for APSA Foundation, but making this a recurring thing I think is a great idea.
Yeah, we were also talking about how much we spend on internet service providers or Netflix or whatever, and $100 is pretty low bar for once a year.
It's like two trips to Starbucks.
It makes a big difference. Yeah.
Well, great. So, guys, I'm curious. We have the second plenary session coming up, and we have some great abstracts talking about CDH and other things. But I'm curious if you guys and maybe people feel free to chat out your responses as well. Is there an abstract that you've seen at APSA that has changed your practice on the spot? Like you heard that abstract and you said, and one that I'm thinking of is Chuck Lie's from a couple of years ago when we were in Boston, the management of spontaneous pneumothorax. And if you were at the case controversies 2 nights ago, it seems like there are a lot of people that have changed their practice. But do you guys have abstracts that you have in your mind that have changed your practice on the spot?
Yeah, I do. I think that spontaneous pneumothorax one is a good one. I think I can think of one from a few years ago that, I mean, and this is an example of the fact that this information is real and it immediately does impact practice. And that would be the laparoscopic exploration for contralateral hernia when there's no physical exam findings of that. And even if you found a patent processus, that the majority of those do not turn into hernias. And so what is the real evidence for doing an exploration? Except, perhaps in a very small category of preemies where they have an anesthetic risk or another risk factor. But I think that that was a real piece of evidence as far as doing routine laparoscopic explorations for contralateral asymptomatic hernia.
That's great. Well, we would love to hear your thoughts on abstracts that have changed your practice on the spot. So put those in the chat. And then also, if you could put things in the chat that had that make the abstract that would change your practice. It's particularly relevant to you. It has tremendously well done study, large study, multi-center. Any of those things would be helpful as we're all considering things in the future. So we are excited for Plenary 2. Don't know how much time we have left, but it's, I think, soon.
think the countdown is on, so probably getting ready to switch over to the next session.
Hello, everyone. Welcome to Virtual APSA 2021 Plenary Session 2. I am one of your moderators, Dr. David Hackham from the Johns Hopkins Children's Center.
And I'm Dr. Baron Modi from Boston Children's Hospital.
And I'm Dr. Barry Rich from Cohen Children's Medical Center.
So we are all members of your 2021 APSA Program Committee, and we're delighted to present 9 fantastic abstracts in this session. Our first abstract in the session will be presented by Dr. Kelly Patterson, a research fellow at Nationwide Children's Hospital. Her presentation is entitled Outcomes Following Implementation of a Level 1 Neurotrauma Activation.
Thank you for the opportunity to present our work. We have no disclosures to report. Timely neurosurgical intervention for moderate to severe TBI has been demonstrated to improve outcomes and reduce secondary brain injury. A level 1 neurotrauma activation was created at Nationwide Children's Hospital with the goal to expedite neurosurgery evaluation and intervention. The objective of this study was to determine if pediatric patients with severe TBI had shorter times to OR and times to PICU with a level 1 neurotrauma activation as compared to level 1 or level 2 activations. The variables measured in this study were time to operating room and time to PICU admission. We created 3 cohorts for comparison. The level 1 cohort consisted of patients activated as a level 1 trauma with head injury and with a head abbreviated injury score of greater than or equal to 3, while the level 2 cohort consisted of level 2 activations with head injury and a head abbreviated injury score of greater than or equal to 3. A head abbreviated injury score of 3 or greater was used for inclusion as it correlates to serious, severe, and critical head injury expected to occur in patients meeting the level 1 neuro criteria. The level 1 neuro cohort, therefore, consisted of level 1 neuro activations based on the criteria created at Nationwide Children's Hospital. And these criteria can be seen listed here and include patients with at least one of the following: an acute intracranial hematoma with greater than 4 millimeters of midline shift, a comatose patient with a unilateral fixed and dilated pupil, a significant penetrating injury to the head, or an obvious severe open cranial injury. The 3 cohorts were compared across time. Level 1 and Level 2 cohorts included patients from 2008 through 2020, and the Level 1 neuro cohort included patients from 2014 to 2020, due to the Level 1 neuro activation being implemented in August of 2014. Time to OR and time to PICU were then analyzed based on patient disposition. The aggregate demographics of our cohort are seen here. 107 patients went to the OR and 682 patients were admitted to the PICU. 66.7% of patients were male and 76.3% were white. The mean age was 6.6 years. Median head abbreviated injury score and GCS were 4 and 10 respectively. After adjusting for covariates, we demonstrate clinically shorter times from hospital arrival to OR incision among level 1 neurotraumas. Level 1 neurotraumas had shorter time to OR by 17.1 minutes compared to level 1 traumas and by 38.4 minutes compared to level 2 traumas. Level 1 neuroactivations were used as the reference value. Corresponding confidence intervals with significant p-values are shown. We also demonstrate clinically shorter times from hospital arrival to PICU admission among level 1 neurotraumas. Level 1 neurotraumas had shorter time to PICU by 8.6 minutes compared to level 1 traumas, and had shorter time by 64.3 minutes compared to level 2 traumas. Limitations are intrinsic to the retrospective design of the study. Additionally, generalizability is considered as this study took place at a level 1 quaternary pediatric hospital over a 12-year timeline, though clustering of patients by year was accounted for in our analyses. In conclusion, a level 1 neuroactivation implemented at our hospital was associated with clinically shorter times to OR and PICU, and it standardized and improved interdisciplinary communication among the emergency department, trauma service, and neurosurgery service. Here's the contact information associated with our presentation. Again, thank you for the opportunity to present.
Thank you, Dr. Patterson. The invited discussant for this paper is Dr. Bindi Naik Mathuria from Texas Children's Hospital.
Thank you. That was an excellent presentation. Very interesting concept, and certainly something that other level 1 trauma centers could adopt. So I have a couple of questions for you. The first is, what was the difference in the activations for the neurotrauma cases compared to the level 1 trauma activations? And the second is, did you compare mortality as an outcome?
Great questions. To answer your first question, the thing that distinguishes the level 1 neurotrauma activations from our level 1 or level 2 activation is that the neurosurgery on-call team will actually also get the page for a level 1 neurotrauma activation. This includes the resident, fellow, and on-call attending. And the attending is expected in the trauma bay within 30 minutes of arrival. We have done some audits for performance outcomes and found that our neurosurgeons usually arrive within 15 minutes. And so additionally, our ICU also gets the page. So the critical care attending as well as the critical care fellow on call will get the page so that they can prepare the room for EVD placement and ICP monitoring, for example. The neurosurgery team actually has their own OR here at NCH. So the OR staff are also alerted when a level 1 neurotrauma comes in, and they will prepare the room and also have a neurotrauma cart that includes all of the neurosurgery instruments and devices that are usually used. And so they can actually transport this cart to another hybrid room if trauma patients require an XLAP in addition to a craniotomy, for example. And then the last thing that actually happens is FFP is brought to the trauma bay. And we do this because our neurosurgery colleagues prefer for the INR to be below 2. And so that is also, those are the 5 things that really occur and go into action when a level 1 neurotrauma goes off. And then to answer your second question, this is a really good question because we definitely acknowledge that looking at mortality is important. If we can get patients to the OR and ICU faster, but we're not really improving their outcomes, is this intervention really beneficial? And so we've done some preliminary analyses on this using our regression models. And what we found is that the mean time to OR did not significantly differ between those patients who were discharged alive or discharged deceased. However, I will say that the mean time to OR for patients discharged alive was close to 100 minutes, while it was closer to 119 minutes for those who were discharged deceased. And we found really similar results in our PICU cohort. And so it's difficult to say whether the main effect on mortality was time based on this. And we really need further analyses to specifically look at interactions among the cohorts. And to look at this in the future, what we'd really like to do is make sure that our sample size is powered appropriately, to also look at some additional covariates that might affect the mortality. So things like abbreviated injury scores across the body regions, ventilator days, for example, mechanism of injury. And so in addition to mortality, the other thing that we've also considered looking into is the cognitive functional outcomes, because we know these can also be really devastating when it comes to TBI.
Great. Okay, well, again, excellent work. I think it's a great idea and something that we might even adopt. We might even steal this from you. It's such a good idea. So I really really appreciate your presentation. Thank you.
Thank you so much.
Thank you both. That's the sign of great work when others want to adopt it. It's absolutely the case. Thank you so much, Drs. Patterson and Naik Mathuria.
Our next abstract in this session will be presented by Dr. Ruth Lewitt, a research fellow from the University of Tennessee Health Science Center at Le Bonheur Children's Hospital. The presentation is entitled Blunt Cerebrovascular Injury in Children, a Prospective Observational Study.
Hello, my name is Ruth Lewitt, and I'll be talking about blunt cerebrovascular injury in children. a prospective observational study. The incidence of BCVI in children is largely unknown. A previous retrospective study found an incidence of 0.7% in children with head and neck injuries. However, only 16.5% of children with risk factors were actually screened. The goal of this study was therefore to determine the true incidence of BCVI, evaluate injury patterns, and identify risk factors in children with BCVI. This was a prospective, multi-institutional observational study of children less than 15 with blunt trauma to the head, face, or neck, as defined by an AIS score greater than 0. 6 level 1 pediatric trauma centers participated from 2017 to 2020. Patients were screened using the Memphis screening criteria, which included cervical spine fractures or ligamentous injuries, skull base fractures, Lefort 2 or 3 fractures, neck or soft tissue injuries, Horner syndrome, or a neurological exam not explained by imaging. If at least one of these criteria was met, a CTA was recommended. 2,285 patients met inclusion criteria with an injury to the head, neck, or face. Of those, 520 met the Memphis screening criteria, and 1,765 did not meet criteria. Of those that met criteria, 222 were screened, and a total of 25 BCVIs were identified, 3 of which did not meet the Memphis screening criteria. The most common mechanism of injury for the entire cohort was an MVC. If you look more closely at the Memphis screening criteria, we first noted that there were 520 patients that met criteria, and of those, only 222 were actually screened for a screening rate of 42%. We also noticed a few other things. First, no patients presented with Horner syndrome or anisocoria. Second, Lefort 2 and 3 fractures were rare, but were highly associated with BCVIs. And lastly, neck soft tissue injuries is a fairly vague criteria and may need to be further specified in the future. We then looked at demographics of the entire patient cohort, those that met criteria, those that were screened, and those that had a BCVI. There were no statistical differences seen in sex, race, or ethnicity between the groups. However, looking at age, those that met criteria, those that were screened, and those that had a BCVI were slightly older. Additionally, those with a BCVI had a lower GCS and higher ISS scores, as would be expected, and also had higher mortality. 25 BCVIs were diagnosed with an incidence of 1.09%. The most common risk factors were basilar skull fractures and cervical spine injuries. Of the 9 patients with the cervical spine injury, 4 had ligamentous injuries only. 6 patients with a BCVI suffered a stroke, with an overall mortality rate of 25%. We then conducted multivariate regression analysis, and we found that crush injuries was the only mechanism that was independently associated with BCVIs. Furthermore, BCVIs were associated with higher AIS scores of the head and neck, chest, and abdomen. We then looked at the interaction between BCVIs and strokes and found that 3 strokes were diagnosed at the same time as the BCVI was diagnosed. Of those that met criteria, 20 had BCVIs, and of those, 3 suffered a stroke. 1 after being treated, and then the other 2 after that did not receive treatment for their BCVI. In conclusion, screening guidelines did improve screening rates from 16.5 to 42%. BCVIs were identified in 1.09% of children with injuries to the head, neck, or face. However, because the screening rates were less than 50%, we do believe that the true incidence is likely higher. And lastly, we believe that modified screening criteria in children is needed. Thank you very much. And here's our contact information if you have any questions. Thank you.
Thank you, Dr. Lewitt. The invited discussant for this paper is Dr. Assam Nasser from Johns Hopkins Hospital.
Ruth, great job presenting. It was a very clear presentation. My first question would be, how would you envision the modified screening guideline to look in the application for children, for the pediatric population?
Well, first of all, thank you very much for doing this. That's an excellent question. it's something that we're still working on. We're still looking at all the data and going through it. That's really the next project on our to-do list. We're looking at both the Memphis criteria and the Denver criteria, as well as some of the Utah screening criteria to see what bits and pieces we think are going to be best. Looking at things like the Memphis criteria, we saw that, for instance, neck soft tissue injuries, there were 111 patients that had neck soft tissue injuries, and of those, only one had a BCVI. And so that may be an area that we can either clarify more, be more specific as to what qualifies as a neck soft tissue injury, and further narrow down the screening criteria so that we're not screening too many people and radiating too many kids.
You mentioned that the true incidence is likely higher because the screening rate was only 50%. What do you think needs to happen in order to improve screening? And would you consider implementing a standardized screening that is embedded in the electronic medical record, maybe in the trauma note?
Yeah, that's another great question. I think part of the problem is education. So a lot of providers, I think, forget to think about BCVIs, especially in this pediatric patient population. It's not something that comes to our minds immediately. So more education and more research like what we're doing to find the true incidence. That's what we're finding is that it really is seen more commonly than we previously thought. So really educating providers, getting more buy-in on what screening criteria should be, should help that. I think that's a great idea to have something embedded within the EMR. As long as it's done properly, I think it would be a useful adjunct.
Yeah, one final question is that, one of your conclusions, which is, very important, is that the screening guidelines improved screening rates from 16.5 to 42%. Tell us a little bit about how the screening was performed, who performed it, was it in the trauma bay? And I think one of the big questions, was there any variation in screening between the 6 different centers? Because you're dealing with the different trauma centers, and was there an outlier, and were there any lessons that you can learn from certain centers?
Yeah, so there was definite variation between the sites. It varied from screening rates between 19 to 55% screening rates at each site. So certain sites did better, and certain sites didn't do as good of a job with screening. I think it was site-based as to who was doing the screening itself. The screening itself could be anywhere from the trauma bay to taking the patient to radiology, or anywhere within the first 12 to 24 hours as you complete the workup of the patient and what injuries the patient has. So it really could be anywhere within that first 24-hour time period. So it was highly variable between the sites, and that's something we can definitely work on in the future.
All right, excellent job.
Thank you so much.
Great. Thank you, Dr. Lewitt from Le Bonheur, and Dr. Nasser for an excellent discussion from Johns Hopkins Children's Center.
Our next abstract in this session will be presented by Dr. Nadia Safa from the Montreal Children's Hospital McGill University Health Center. Her presentation is entitled Treatment and Outcomes of Prenatally Identified Ovarian Cysts, a study by the Canadian Consortium for Research in Pediatric Surgery.
Thank you to APSA for the opportunity to present. I'm Nadia Safa, and I will be presenting on behalf of the Cancor group. We have no disclosures. Ovarian cysts are the most common cystic abdominal mass necessitating referral to a pediatric surgeon. There is general consensus that small, simple cysts will resolve spontaneously. However, controversy still exists regarding the management of large, simple cysts and complex cysts due to various associated complications such as ovarian torsion, hemorrhage, and bowel obstruction. However, it remains unclear if operative interventions actually improve ovarian salvage. The aim of the study was to estimate the incidence of spontaneous ovarian cyst resolution, to determine clinical predictors of surgical management, and to compare the effects of surgical and non-surgical management on ovarian preservation. Ovarian preservation in this study was defined as sonographic identification of a viable residual ovary after observation, or a surgical documentation of an ovary-sparing surgical procedure. We conducted a national multi-center retrospective cohort study under the auspices of a new national pediatric surgery research consortium called Cancor. The consortium was founded in July of 2018 and includes 15 academic pediatric surgical services in Canada. This study represents the first study conducted by Cancor, which was anchored at the Montreal Children's Hospital. Patients with congenital ovarian cysts diagnosed between 22 weeks gestation and 3 months of life were included within a span of 5 years. Patients were excluded if the abdominal cyst was found to be non-ovarian on postnatal ultrasound, or if there was incomplete sonographic follow-up of the cyst trajectory. Standard descriptive statistical tests were performed, and logistic regression was used to determine predictors of surgical management and to compare ovarian preservation between surgically and non-surgically managed groups. After excluding patients based on the aforementioned exclusion criteria, our study cohort consisted of 189 patients with congenital ovarian cysts. Out of these 189 patients, 173 patients were born with an ovarian cyst. In total, 103 patients had spontaneous cyst resolution in the postnatal period after non-surgical management. 13 patients had persistence of an ovarian cyst after 1 year. A total of 131 patients were managed non-surgically, compared with 22 patients who underwent early surgery. Complex sonographic features and cyst diameter greater than 40 millimeters were statistically significant predictors of early surgical management. After an initial observation period of at least 3 months, 103 patients had spontaneous cyst resolution, whereas 15 were managed surgically. Those managed surgically after a period of 3 months of observation had larger ovarian cysts and were more likely to have complex features. The median time to cyst resolution for complex cysts was 320 days, compared to 82 days for simple cysts. And finally, when we compared patients who underwent early surgery within the first 3 months of life and those who were initially observed, there was no difference in the odds of ovarian preservation. This was similar in both subgroup analyses of patients with complex cysts and those with cysts larger than 40 millimeters in diameter. Overall, our study represents the largest study on patients with congenital ovarian cysts. Limitations include a lack of standardized management protocols and a lack of long-term follow-up, so no conclusions can be drawn about the viability of those residual ovaries. In conclusion, the vast majority of congenital ovarian cysts resolve spontaneously within 1 year. Cyst size and complexity predicted surgical management decisions, and surgical management did not increase ovarian preservation. Finally, observation seems to be a safe option that may lead to the avoidance of many unnecessary surgical procedures in young infants. In the near future, we plan to create a consensus algorithm for workup and management of congenital ovarian cysts, which will be prospectively evaluated across Cancor sites. Thank you to everyone who is a part of Cancor for their contributions to this project, and thank you to the Morella and Lina Saputo Foundation for supporting the Cancor infrastructure. And thank you all for your time.
Thank you, Dr. Safa. The invited discussant for this paper is Dr. Erin Perrone from Mott Children's Hospital at the University of Michigan.
Dr. Safa, this was a great study that you presented very well. Can you let me know if the Cancor's protocol or algorithm is going to be shared with the rest of us?
Yeah, absolutely. So the algorithm is not finalized yet. It's currently under review by all of the Cancor co-authors. So we're not ready to share it with APSA quite yet. But once we're ready to publish our current findings, we hope to include it in the publication so that it's available to everyone. We eventually plan to conduct a prospective cohort study to evaluate its applicability in the clinical setting. Hopefully we'll need about 1 year to accrue enough patients and follow them for another year after that. So hopefully that study will last about a total of 2 years. But yes, that algorithm will hopefully be available to everyone soon.
Wonderful. And you said 2 years. So how many of your institutions are going to be able to participate in that?
We're hoping all 15. That's the ideal goal. But right now we have 10 centers participating in this current retrospective study. So at least those 10 centers will be participating in the prospective one, hopefully.
Great. So if I understood your presentation right, you showed that there was no difference between ovarian salvage or differences in complication by waiting for surgery. So can you let me know if there's any indication for an operation on a neonate that you would give me?
Yeah, I think it's important to go back to why surgeons choose to operate on congenital ovarian cysts in the first place. One of the first reasons people choose to operate is they're worried about cyst torsion. In our population, we had 32 patients who had a change in ultrasound character from simple to complex, all of which occurred by the time they had their first postnatal ultrasound, which occurred about a median age of 1 week. So early surgery to prevent torsion, we don't think is really possible based on the natural history of these cysts. Another reason people choose to operate is that they're worried that they're missing another pathology. But again, for a cyst that persists or enlarges postnatally, that's really the reason to doubt the diagnosis. The natural history of these cysts is once the maternal hormonal stimulation kind of disappears after about 3 to 4 months, most of these cysts will actually regress or resolve. So when a cyst persists or enlarges after a period of observation, then there's a reason to doubt the diagnosis. And maybe then diagnostic laparoscopy can be used to help clarify whether a cyst is truly ovarian in nature.
May I just add a couple of points, Erin? I think a good question is, when is it not ovarian? Because we assume that the overwhelming majority of cysts in girls are ovarian. In fact, about 90% are. But it is an important differentiation because we tend to be very conservative now with ovarian cysts, but most non-ovarian do in fact need a resection. So we actually are performing a sub-study of our data because we had a significant cohort, about 10% that were not. But I think one of the important points is that we've often thought of complex cysts as the ones that should be operated, because those are the ones that torch, maybe you can still salvage something, or maybe they'll cause complications. And I think we are saying exactly the opposite. You can observe these complex cysts for an entire year. They are very likely to lead to any complications, and the ovary is already lost. So really the issue becomes what to do with the simple ones. And if a simple cyst, as Nadia is saying, continues to grow, then you really have to doubt the etiology, because that's not the natural history of an ovarian cyst. So that would potentially be an indication for operation somewhere between 3 and 6 months.
Well, thank you so much. That was a great presentation. I really appreciated being able to see it.
Thank you.
Thank you for reviewing our study.
Thank you, Dr. Safa and Perrone.
Our next abstract in the session will be presented by Ms. Dorothy Lee, a graduate student at the Hospital for Sick Children in Toronto. Her presentation is entitled Glial Cell-Derived Growth Factor Enhanced Enteric Neural Progenitor Migration in an Embryonic Gut Explant Model of Hirschsprung's Disease.
Hello everyone. Today I'll be presenting about using growth factor, glial cell-derived neurotrophic factor, to induce enteric neural progenitor migration as a novel therapy for Hirschsprung's disease using an embryonic gut explant model. This project is carried out in collaboration between the Hospital for Sick Children and Juntendo University. Hirschsprung's disease is characterized by the absence of intrinsic ganglion cells in the plexus layers of the hindgut. With the current treatment of surgical removal of the aganglionic colon, there are still numerous postoperative complications, including enterocolitis. Despite recent efforts in experimenting with cell transplantation as an alternative therapeutics for Hirschsprung's, there are still limitations that remain with cell application. Instead of giving an exogenous source of cells, we could also perhaps make use of known protein factors. As a neurotrophic factor, GDNF is a protein known to promote migration, survival, and differentiation of enteric progenitors. This leads us to the aim of our study, which is to determine the effect of GDNF on migration of enteric progenitors in experimental Hirschsprung's disease mouse model. As a model of Hirschsprung's disease, I have utilized the genetic knockout mouse model with EDNRB deletion, which generates mutant mice with megacolon and aganglionosis. In order to determine the migration of enteric progenitors, I have crossbred EDNRB mutant mice with SOX10 venous transgenic mice that labels enteric progenitors with fluorescent label GFP, which allows me to track the migration of these cells during the experiment. I isolated the guts of control and EDNRB mutant embryos that express SOX10 venous transgene at E11.5, at which previous studies have shown to be more permissible for neuromigration. These guts were embedded in matrigel and are cultured in either control media or media supplemented with GDNF. After culturing for 48 hours, live imaging was carried out. First, let's look at migration assay of wild-type explants. In the control media group, SOX10 positive cells can be observed along the embryonic gut tissue. For explants cultured with media supplemented with GDNF, since the media is given outside of the matrigel dome, the SOX10 positive cells will want to migrate towards where the GDNF is, thus the formation of neural-looking extensions. These neural extensions can be observed when GDNF is given at different dosages, at low dose 100 picogram per milliliter and high dose 100 nanogram per milliliter. And as you can compare between these two groups, effect on migration can be seen stronger when given a higher dose of GDNF. Migration assay on EDNRB knockout expanse was also carried out. When the expanse is cultured with control media, again, no migration or neural extensions outside of the tissue can be observed. However, when high-dose GDNF is added into the media, outward migration can be observed of the SOX-positive cells. Quantification is carried out, measuring the length of neural extensions from the edge of the tissue to the end of the extensions, which is a measure of migration ability. Among the wild-type expands, both low and high-dose GDNF treatments showed significant migration compared to control. And there is also a significantly longer migration length of the higher dose compared to the lower dose. When comparing between the GDNF-treated EDNRB knockout expands to the control media group, there is a significantly longer migration when GDNF is administered to the mutant expand, demonstrating that even with EDNRB deletion, the migration ability of SOX-positive enteric progenitors is not completely abolished and can be induced when given an exogenous source of growth factor GDNF. In summary, administration of GDNF significantly enhanced enteric progenitors migration in both EDNRB knockout and wild-type embryonic gut expands. These findings open the way to the development of a novel treatment for Hirschsprung's disease. At last, I would like to thank everyone in the Paralab for their help in this study. Thank you.
Thank you, Ms. Lee. The invited discussant for this paper is Dr. Allison Spear from Children's Memorial Hermann Hospital at UT Houston.
Dorothy, thank you so much for your presentation today and congratulations on your exciting study. You showed that GDNF enhanced your enteric progenitor migration both in wild type and your EDNRB knockouts. But how do you intend to control the direction of migration? For example, from cranial to caudal rather than just radially?
Thank you very much for your question. So for our study, we first wanted to confirm the effect of GDNF in promoting enteric progenitors migration by adding the factor to the media surrounding the whole tissue, thus the radial migration as you have observed. And now that we have confirmed the migratory effect of GDNF, we are actually currently optimizing the method of delivery through soaking porous agarose beads with GDNF and then strategically placing them at the distal end of the aganglionic gut, expecting the chemical attraction of GDNF will allow these enteric progenitors to move along the gut from the ganglionic portion towards the aganglionic distal part.
It's a smart solution. Heather Young and Lincoln Stamp have previously demonstrated in an alien study that GDNF enhanced their enteric progenitors, both neurosphere number and size, but also migration, similar to your study. They interestingly showed that GDNF with retinoic acid was actually synergistic. Have you done any studies with retinoic acid or other growth factors?
Thank you very much for your interesting question. In our study, we wanted to first ensure that the enteric progenitors from an EDNRB knockout intestine can actually still be triggered to migrate when given an exogenous source of growth factor, such as GDNF, which my data has successfully proven. And actually, it is in our future experimental plan to test if a combination of more than one factors, such as adding retinoic acid, as you have mentioned, or things like neurotrophin factors. And if this can synergistically have a stronger effect in promoting migration than when giving GDNF alone.
Great. In your studies, you utilized embryonic gut, and we know that enteric progenitors can migrate more actively prenatally than postnatally. But we also know as pediatric surgeons that Hirschsprung's is typically diagnosed postnatally. So your therapies or growth factors would be given postnatally. Do you think that they'll be equally efficacious?
Thank you very much for your question. So according to a recent paper published in Gastroenterology, Hugueruth and Pillen were able to show that with enema delivery of GDNF to postnatal mouse models of Hirschsprung's disease, they were actually able to observe some evidence of possible Schwann cells migration. And we believe that perhaps by increasing the dose of GDNF being delivered on top of a repeated enema delivery, we might be able to observe a more significant migration of enteric neurons at a postnatal stage.
I'm so glad you brought up that paper because it brings up the question of how you give your growth factors. And do you think enema is the way to go moving forward, or do you think something like colonoscopy or surgery will be necessary to give an injection directly into the muscularis of children?
Yeah, thank you again for your question. So as mentioned in Kirkwood and Pillen's paper, they were able to actually show efficacy of GDNF through enema delivery. And since enema is actually commonly performed with in children with Hirschsprung's disease in order to relieve constipation before performing pull-through operation. So we feel that an enema to achieve the delivery of GDNF will be a good translational approach.
Dorothy, thank you so much for your presentation and your answers. We're really looking forward to what's coming out of your lab next.
Thank you very much for your questions.
Thank you, Ms. Lee and Dr. Spear.
Our next abstract in this session will be presented by Dr. Vikas Gupta, a research fellow from the McGovern Medical School at UT Health, whose presentation is entitled Prenatal Imaging Measurements Correlate with Early Postnatal Pulmonary Hypertension and Cardiac Dysfunction in Congenital Diaphragmatic Hernia.
Thank you for the opportunity to present our work. It is a privilege to share the virtual stage with the other presenters during this plenary session. We have no disclosures. The fundamental clinical challenges in congenital diaphragmatic hernia are pulmonary hypoplasia, pulmonary hypertension, and ventricular dysfunction. All three of these factors are strongly associated with disease severity and patient outcome. Despite their importance, data regarding prenatal predictors of pulmonary hypertension and ventricular dysfunction are lacking. There are, however, a number of prenatal imaging parameters used to evaluate pulmonary hypoplasia. The lung-to-head ratio is often determined on an ultrasound done in the late second trimester. An LHR of less than 1 predicts poor outcome for CDH infants. The LHR was then adjusted to create the observed to expected LHR. This corrects for gestational age. As you can see, the OTE LHR can be used to risk stratify infants on a more granular level. Fetal MRI is also an important tool in prenatal management of CDH infants. In the observed to expected total lung volume, the absolute lung volume of the infant in utero is compared to age-matched controls. Previous literature suggests that an OTE total lung volume of less than 25% predicts mortality for CDH infants. Finally, fetal MRI can also be used to calculate the percent predicted lung volume in CDH. The predicted lung volume is based on thoracic and mediastinal size. A PPLV of less than 15% predicts mortality for CDH infants. The purpose of our work was to assess the utility of these fetal ultrasound and MRI measurements in predicting CDH-associated pulmonary hypertension and cardiac dysfunction in the first 48 hours of life. We performed a retrospective review of patients in the CDH study group from 2015 to 2020. These years correspond to version 4 of the CDH study group registry, which is the first iteration to collect both prenatal imaging measurements and echocardiographic data. Prenatal data were collected from the initial prenatal ultrasound or fetal MRI, and the outcomes of interest were the presence of early pulmonary hypertension or ventricular dysfunction, which was determined on echocardiograms performed in the first 48 hours of life. Receiver operating characteristics and univariate analyses were performed. There were 2,822 patients total in the CDH study group during this time period. Of those, 1,434 patients had prenatal ultrasound data, and 944 patients had fetal MRI data available. Both LHR and observed to expected LHR were significantly higher in patients without pulmonary hypertension than those with pulmonary hypertension in the first 48 hours of life. Similarly, the observed to expected total lung volume and percent predicted lung volume were also higher for patients without pulmonary hypertension. Prenatal parameters showed the same association with ventricular dysfunction. Both ultrasound and fetal MRI parameters were higher in patients with normal ventricular function than in patients with early ventricular dysfunction. Ultrasound parameters were satisfactory markers for predicting the presence of early pulmonary hypertension. Fetal MRI measurements outperformed ultrasound, and O/E TLV was a good predictor of CDH pulmonary hypertension with an area under the curve of 0.79. We saw a similar trend when predicting early ventricular dysfunction. As you can see, the ROC curves for ultrasound values were relatively flat when predicting early ventricular dysfunction. Again, MRI measurements outperformed them, and percent predicted lung volume was a good predictor of early ventricular dysfunction with an AUC of 0.71. In conclusion, fetal ultrasound and MRI measurements are associated with early pulmonary hypertension and ventricular dysfunction in diaphragmatic hernia. Specific MRI measurements may be predictive markers of early pulmonary hypertension and cardiac dysfunction, and while additional investigation and refinement of these techniques are needed, These data can be used to counsel families in the prenatal period once the diagnosis of CDH is established. Thank you. I am now open for any questions.
Thank you, Dr. Gupta. The invited discussant for this paper is Dr. Tim Jenselowitz from the University of Tennessee Health Science Center at Le Bonheur Children's Hospital. Tim?
Thanks so much. That's a great presentation. And I think these data are so incredibly important, not only because early risk stratification in CDH is fundamental to designing appropriate care for these infants after birth, but it's also used to determine candidacy for fetal intervention. So a big problem that your work identifies, to my mind, is that what is obtained prenatally is inconsistent center to center. So my first question is, how consistent is the utility of MRI and ultrasound center to center, and is there, or did you discover any uniformity in practice?
So that's obviously a great question, Dr. Jenselowitz, and something that we thought about a lot when doing this work. So one major limitation of fetal imaging is that it is highly variable. There are only a few fetal centers around the country that manage CDH infants, and their protocols are likely different in terms of what gestational age they get the imaging, different methods of calculating the measurements, different technicians, different interpretations of those measurements. And so that variability likely contributes to why we had relatively low sensitivity and specificity in our results, especially on the prenatal ultrasounds. I will say that for the manuscript, we are going to stratify and look at variations between centers. I think that data will be a little bit limited because it's going to dilute the numbers a lot based on the number of centers that we have. Each place is only contributing a few patients each. And preliminarily, though, we found that there are more and more ultrasounds and MRIs being done through the study period. So we looked at 2015 to 2020. There's a higher percent of patients getting the prenatal imaging studies in 2020 that there were in 2015. And so we're probably going to see more and more places doing these imaging modalities more frequently over time.
Okay, thank you. And then, so you mentioned that your sensitivity and specificity is good. It's not that great. So why aren't these predictors more sensitive and specific than you have reported? And do you think that these tests are tending to overestimate or underestimate severity, or both?
So I definitely agree with you. This is probably a limitation of all fetal imaging in CDH. As you know yourself, Dr. Jenselowitz, there are a ton of different ways to risk stratify CDH infants, both pre and postnatally. And it's likely that in their current form, fetal imaging could be either over or underestimating disease severity. I don't know the exact answer. Like I mentioned at the very beginning of the presentation, CDH is driven by multiple factors. Pulmonary hypertension and ventricular dysfunction are just part of that clinical picture. So in some soon to be published work by the CDH study group, we found that the prenatal measurements are really good at risk stratifying patients by defect size, which many people agree is an important predictor of outcome. And this is especially true for left-sided CDH. So just a small example, prenatal imaging measurements were similar for D-size defect, which is complete diaphragmatic agenesis, and patients that died before even getting their diaphragm repaired. So the most severely ill patients. Having said that, even though these measurements are good, not great, I would be hesitant to rely solely on prenatal data to guide clinical decision-making. There's obviously a lot more work to be done.
Great, well, that ties into my last question, which is how can we use this information for our patients? And what might be next steps in research to improve our discrimination prenatally?
Yeah, absolutely. I think that's an important question. So these data are helpful in a few ways clinically. One is knowing that we might be able to assess pulmonary hypertension and ventricular dysfunction ahead of time. More and more patients probably should obtain fetal imaging if they are able to be seen at a fetal center. From there, if a patient is identified to have prenatal measurements that are correlated with pulmonary hypertension and ventricular dysfunction, perhaps they should be counseled to deliver the child at a center that has the infrastructure and personnel to manage severe pulmonary hypertension and ventricular dysfunction. So critical, high-level NICU, ECMO capability, et cetera. Second, and we also talked about this a little bit already, is we need to use these data to generate more multi-center investigation and work on standardizing the use of fetal imaging in CDH. But on a basic and translational level, we need to understand the pathophysiology of CDH-associated pulmonary hypertension and ventricular dysfunction. So just as a small example, in our basic science lab, we found that CDH lungs are severely hypoxic and inflamed in utero compared to control lungs. And so ongoing work in this prenatal CDH area may identify therapeutics that can be used in utero to help CDH infants in the future.
Thank you very much.
Thank you, Dr. Gupta and Dr. Jenselowitz.
Our next abstract in this session will be presented by Dr. Yeet Gunnar from the University of California at Irvine. His presentation is entitled Risk-Adjusted Standardized Mortality Ratios Among Neonates with Congenital Diaphragmatic Hernia on Extracorporeal Life Support, study by the ELSO-CDH Interest Group.
Thank you. Diaphragmatic hernia is the most common indication for neonatal restore ECMO. It remains unclear how much the mortality associated with ECMOs and CDH differs across different centers. Ryan Barbara looked at neonatal ECMO, not specifically CDH, but neonatal ECMO, and demonstrated that there was an 18 to 50% variation across different also centers in terms of mortality, which was volume outcome dependent. Similar results were shown by the Canadian Pediatric Surgery Network, where high volume centers had better outcomes compared to low volume centers. And Dr. Jansen-Lewis recently looked at the CDH study group data by breaking down patients into their risk profiles, low risk, medium risk, and high risk, also demonstrated differences based on volume and outcome in ECMO use. However, no previous study was specifically designed to compare one center to the next and look for differences in treatment after adjusting for case mix or disease severity in terms of mortality, which was the purpose of this study. We used the ELSO registry data for the last 20 years and looked at single ECMO run cases. 86 centers were excluded due to not having adequate number of cases, which left us with 109 centers. The primary outcome was standardized mortality ratios, which was adjusted for case mix, including the variables below, which was pre-ECLS variables present in the ELSO registry. Here are what our results showed. As you can see, most centers had mortality ranging from 40 to 60%, a few having lower or higher. And volume, most centers had less than 50 patients per the 20-year period, and a few others having more. These are the variables to which we adjusted our standardized mortality ratios to. This logistic regression model shows these variables contributed to mortality prior to ECLS that are present in the ELSO registry. And here's our main results panel. What you see is each dot is a standardized mortality ratio. If the standard error bars cross the one line, there's no difference from center to center as far as the risk-adjusted mortality ratios. However, we flagged 13 as significantly better, as having favorable outcomes or mortality, compared to 7 having significantly worse. Then we asked, why could that be? We compared the 13 to the 7 centers, the significantly better to significantly worse, and found the following differences in treatment. What you see here is, again, these are risk-adjusted and found to be different than each other, 13 versus 7. The mean airway pressures were higher at significantly worse centers prior to ECMO, and their use of conventional ventilator was less, or they are more likely to use high-frequency ventilators prior to going on ECMO. Timing of CDH repair was also significantly different, and specifically post-ECMO repair was more common at significantly better centers, and they were less likely to have non-repairs. Significantly better centers were more likely to use inotropes, less likely to use inhaled nitric oxide, and more likely to use steroids prior to ECMO. Renal complications and infection complications were more common in significantly worse centers, and needing to come off of ECMO due to a complication was twice as more common in significantly worse centers. Overall, the 13 versus the 7 centers did not have differences as far as center volume. However, this study was not designed to compare volume outcome. Limitations of our study include retrospective data and missing data. We imputed the missing data, and our results did not significantly change. In conclusion, we started with 109 ELSO centers. After risk adjusting their mortalities, we identified 13 as significantly better and 7 as worse. We asked why, and we identified multiple differences in treatment as well as complications. Thank you.
Thank you, Dr. Gunnar. The invited discussant is Dr. Alex Garcia from Johns Hopkins Children's Center.
Yes, hi, Dr. Gunnar. Thank you for your excellent presentation and sharing your research with us using the ELSO database. I had a few questions for you. My first question is, do you think that certain centers had earlier thresholds or cutoffs for initiating ECMO, and how could that have affected the outcome you found?
It does appear that that's a reasonable hypothesis based on some of the findings when we compare the 13 and the 7 centers to each other, the better versus worse centers. But the mean airway pressures were slightly lower in the better centers, and they were more likely to use a conventional ventilator than switching to ECMO, which is perhaps not the practice in many places. But I think that is perhaps a next study we could look into. But that is my understanding, looking at the data as to where we could go next.
My next question was that the ELSO database doesn't really account for the severity of CDH patients, such as having LHR or liver up, known prenatally. So how much do you think that influences the outcomes, given certain, or what you call worse performing centers, could have been patients that have centers that have had higher acuity patients, such as fetal intervention patients and whatnot?
Thank you. It's a great question. This comes up quite often. So in this case, I think what ELSA does do a good job of, at least reasonable, is accounting for having variables that can then be accounted for risk of ECMO patients. Now, we're not specifically comparing, say, CDH patients to PPHN or other groups that needed ECMO. So we're just looking at a cohort of CDH patients who ended up on ECMO. And so we know their pre-ECMO or ECLS variables. So we know which ones had lower pH, which ones were handbagged perhaps, or had more severe physiologic symptoms based on what ELSA collects. Now, the other thing is that there really isn't a registry that has many, many years of LHR or liver or MRI measurements of lung volumes. And that's not always done the same at different institutions. So there's a lot of variability. It would be wonderful to have that information. But I think for what we have, even looking at the raw mortality rates, the centers that have high mortality it ranges from 70 to 80%. That's very high. I don't think any centers that have, fetal centers have mortalities in that range.
My last question for you is that the ELSO database has always been critiqued for the poor quality of data, but I know that over the last 4 or 5 years that has improved significantly. How does the quality of the ELSO data affect your clinical recommendations that you would give based on your research?
Good question. I think we can just look at it, just for research purposes. And what we did actually in the manuscript is we did a sensitivity analysis of looking at the years in 3 different epochs. And it didn't change the finding that those centers who were flagged as good and bad, they were still flagged despite the year correction into our analysis. There are differences in quality across centers that provide ECMO for CDH. And my answer to that question would be standardization of care as much as is possible. And I think that's sort of where we need to go.
I think we can all agree with that. That's all the questions I have. Thank you again for your presentation.
Thank you so much.
Excellent discussion, and thank you both so much. Thanks to Dr. Garcia and Gunnar.
Thank you.
Thanks. Our next abstract in this session will be presented by Dr. Natasha Seaman from Children's Hospital of West Ontario. Her presentation is entitled Survival Effect of Complete Surgical Resection of the Primary Tumor in Patients with Metastatic High-Risk Neuroblastoma in a Large Canadian Cohort.
Thank you for the opportunity to present our work. I have no conflicts of interest to disclose. This was a multi-institutional study, but the culmination of my research project during fellowship at the IWK Health Centre in Halifax, Nova Scotia. Previous research had shown us that the role of surgery in stage 1 to 3 neuroblastoma is clear, but the role in stage 4 high-risk disease has not been so. While some studies have shown us that there is a survival benefit with surgery, others have not. In addition to this, the surgeries can be morbid with up to a 20% complication rate. The objective of this study was to determine if the extent of surgical resection affected survival in a pan-Canadian cohort of INSS stage 4 high-risk neuroblastoma. We accessed the Cancer in Young People in Canada program, otherwise known as CIPSI. This is a public-funded, population-based surveillance study that functions in conjunction with the C17 Council, which is the council of all 17 pediatric hematology oncology centers across Canada. Research personnel at each site who are trained by CIPSI collect the data. We included all INSS stage 4 high-risk neuroblastoma between 2001 and 2019. Stage 4S patients were excluded. Primary endpoints were overall and event-free survival. Covariates we looked at were age, sex, decade of treatment, immunotherapy, and tandem stem cell transplant. Statistics used were Kaplan-Meier survival and Cox proportional hazards regression. 376 patients were identified. Unfortunately, 200 patients from Ontario, which is Canada's most populous province, had incomplete surgical data. An additional 36 patients from the CIPSI database had missing data, leaving us with a complete set of 140 patients. Seen here are the cohort characteristics. You can see that just under 50% had a complete surgical resection and just over 50% had an incomplete surgical resection. There was no difference between the two groups. On univariable analysis, complete surgical resection had a statistically significant effect on event-free survival. And the same was true for overall survival. And of each of the variables studied, surgical resection was the only one that was statistically significant. On multivariable analysis, when adjusting for all of the other variables, complete surgical resection was a statistically significant effect on event-free survival. And the same was true for overall survival. Again, when adjusting for all of the other variables, complete surgical resection was the only variable that had a statistically significant effect on overall survival. Limitations of this study include the fact that it was retrospective in nature and we did access a database. We also had a lack of tumor biology data. Some may infer that it is the ability to achieve a complete resection and not the actual resection itself that portends the survival benefit. However, I think we can conclude that surgery still plays an important role in the treatment of these patients, and that in this study, complete surgical resection had a statistically significant effect on both event-free and overall survival in stage 4 high-risk neuroblastoma patients. Thank you.
Thank you, Dr. Seaman. The invited discussant for this paper is Dr. Krista Grant from Penn State Children's Hospital.
All right, thank you for an excellent paper, Dr. Seaman. I really enjoyed the fact that you combined data from multiple Canadian centers, and I just have a few questions. The first question is, as you know, there's no standardized way of discussing extent of resection in neuroblastoma. So how did you define complete resection?
So the completeness of surgical resection was actually abstracted by the trained CIPSI research personnel at each site, and it was provided as an integer, so either complete or incomplete. But for internal validity, the 3 surgeons who were involved in this study actually looked at their own OR reports and the CIPSI data at their institution, and we did find that the data was quite accurate.
Okay. And another thing we know is that primary site in neuroblastoma can affect outcomes. So were you able to tell what percentage of your patients had extra-adrenal neuroblastomas?
Unfortunately, we did not have information from the database about the primary site of the tumor.
Okay, all right. And then in terms of completeness of the data, more than half of your potential patients had incomplete data. Can you talk about what that data was that was missing and what you would do differently if you were designing this database?
So Ontario, which is the largest province in Canada, started collecting data through their own group, which is the Pediatric Oncology Group of Ontario, or POGO, prior to the initiation of CIPSI. And they collected their data in a different way, which meant that the data that we had was not compatible with the CIPSI data. And it had incomplete surgical data. And because that was our main exposure of interest, we really felt like it was not appropriate to include it. However, there has been significant work in the last few years to harmonize the data between POGO and CIPSI, and going forward, this data will be much more in line. And for future studies, I think it will be much more useful to be able to include all the Canadian patients in the database.
Okay, excellent. And then I know that your data span both the INSS and the INRG staging systems, but I was interested in why you chose H2 as a cutoff, since INRG chooses 18 months.
Yeah, the CIPSI database did not provide any identifying data to us, so we don't have any date of birth, and age was therefore provided to us as an integer. So we had 0, 1, 2. 18 months certainly would have been the ideal, but unfortunately we didn't have that, so we chose 2 as what we thought was probably the closest comparison.
Okay, perfect. And then my last question has to do again with the database. I think it should be commended in terms of the breadth of data and including multiple centers over Canada. But what would you do differently in the future? And specifically, how can surgeons make their operative notes and their note-taking in general be more useful for databases?
Definitely. So I think going forward, it's really important for us to standardize the way that we report these surgeries for neuroblastoma. And there was a recent publication, which was a collaborative between the COG, SIOP, and the German Society of Oncology, where they suggested a synoptic OR report for all neuroblastoma surgeries, which would be used internationally. So I think this would be very helpful because we would then be able to have a more objective measure of the surgical resection, which would allow us to then interpret the data more completely.
Okay, absolutely. I think that would be great. Thanks a lot, Dr. Seaman, for a nice
Thank you.
Thank you, Dr. Seaman and Grant. We really appreciate it.
Our next abstract in this session will be presented by Dr. Gail Besner from Nationwide Children's Hospital. Her presentation is entitled Development of an Academic RVU System to Promote Pediatric Surgical Academic Productivity.
Thank you for the opportunity to present our work on development of an academic RVU system to promote pediatric surgical academic productivity. As we know, surgeons have always played a vital role in clinically significant scientific discovery. However, there are recent challenges for promoting academic productivity, including increasing clinical demands and incentivization for pure clinical activity. The objective of this work was to analyze the effects of adding an academic RVU scoring system to an existing work RVU-based incentivization plan on academic productivity. Prior to 2012, incentive bonuses in our department were mainly based on clinical work RVU activities. Starting in 2012, a weighted scoring system for 30 specific academic RVUs was established. Incentivization for work RVUs versus academic RVUs was based on the clinical full-time equivalent of each faculty member. Academic activities incentivized included grant submissions and funding, publications, national presentations, study section participation, education and mentoring activities, receipt of research or teaching awards, initiation of IRB protocols, academic society committee membership activities, and patents. Academic productivity was analyzed from 2012 to 2020. This is what a faculty member's incentive plan looks like. Note that anything highlighted in yellow is individualized and dependent on the clinical FTE of the individual, including the weighting of clinical versus academic pursuits, the number of work RVUs, and the number of academic points to be obtained. Each of the goals to follow is appointed a threshold easiest to achieve, target expected achievement, and maximal hardest to achieve value. For this individual, who's 100% clinical FTE, 40% of their incentive is based on their work RVUs, but this could be less for an individual with protected research time, significant administrative commitments, etc. Next, there are group goals, which typically has included a 1, 2, or 3% increase in work RVUs for the group as a whole, accounting for 3% of the incentive. Additional group goals change annually, accounting for 12% of the incentive. Each faculty member has several personal goals, accounting for 10% of the incentive. Each has teaching attendance goals, accounting for 5% of the incentive. And here are the 30 academic goals that I referred to earlier. Each goal is assigned a certain number of points. For example, 1 point for being the first or senior author on a peer-reviewed manuscript or giving a national presentation, 2 points for a trainee receiving an award at a national meeting, etc. Similar to the work RVUs, the weighting of the academic goals and the number of points to be achieved are specific to the clinical FTE of the faculty member. After initiation of this program, our annual external grant funding increased from $750,000 to almost $5.8 million a year in 2019, a 7.7-fold increase. Our peer-reviewed manuscripts increased from 24 to 140 a year, a 5.8-fold increase. Our total abstract acceptances doubled, and our APSA abstract acceptances tripled. And our research fellows received 41 awards at national meetings, including 6 APSA Folkman or Best Research Awards and 2 APSA QI Awards, 8 AAP Section on Surgery Rosencrantz Awards, and 1 AAP QI Award, and many others. In conclusion, incentivization based on the addition of an academic RVU system to a pre-existing work RVU system was associated with a significant increase in academic productivity, and clinical productivity increased simultaneously. Based on our findings, we believe that implementing an academic RVU program is an important means of increasing academic productivity. I would like to acknowledge Dr. Larry Moss, Surgeon-in-Chief at the time, who supported my development of this system, as well as all of my practice partners who have produced the results that I showed you today. Thank you for your attention. This is my contact information, and I'll be glad to answer any questions.
Thank you, Dr. Besner. The invited discussant for this paper is Dr. Steven Stylianos from the Morgan Stanley Children's Hospital at Columbia University.
Thank you. As expected, Dr. Besner just delivered a clear and effective presentation on an incentive strategy that many could begin using tomorrow. I can hear our surgical forefathers grumbling on how they always, quote, took all things into consideration, end quote, when determining a faculty bonus or raise. However, Dr. Besner has shown us that a transparent, prospective, and consistent process paid great dividends in academic productivity for their group. I have a few questions. Were there data gathered on faculty satisfaction with this hybrid weighted scoring system? And did the faculty members feel that the implementation was equitable? Second, who gathered and scored the data elements? Third, and maybe most importantly, could the impressive increase in academic productivity over the study period have been more as a result of the exceptional recruits to your faculty and not simply due to the weighted scoring system? And finally, in many groups, bonuses are awarded with any surplus funds at the end of an academic year. Any advice for groups that may adopt a similar complex incentivization plan and then have no surplus funds to award? It has been a pleasure to kick off the discussion of this provocative presentation, and I thank you for the invitation and opportunity.
Dr. Stylianos, thank you for those very astute questions, and I'll try to answer them one at a time. Your first question was on faculty satisfaction. And although I didn't do a formal questionnaire regarding satisfaction, I firmly believe that incentives should be achievable and reachable, and they should be a true incentive rather than a disincentive. And so when formulating these incentives, I do it with the faculty member, and I do it in such a way that I make sure that the incentives are fair and equitable. And then I reassess the results annually to make sure that in general, the faculty can achieve the incentives that were put forth, because I think that's really an important component of this whole entire enterprise. In terms of who gathered and analyzed the data, I have each faculty member fill out a very detailed, it's about a 6-page faculty development form on an annual basis. And I meet with the faculty at least twice a year. And at the end of each academic year, the faculty member and I sit down and review their faculty development form. And it has all of the details of all of the achievements that they've made during the academic year. And then twice a year, they also provide an updated CV to me in preparation for my twice annual meetings with them. So I really have all the data at my fingertips and therefore can analyze them quite easily. Your third question was about exceptional recruits, and clearly that is a component of our success, but it's not the entire answer. And one thing that I'm really pleased about is that all of the faculty members, irrespective of their clinical FTE, have contributed greatly to our academic progress. And even people who are 100% clinical FTE have received grants, they've gotten awards at national meetings, and they've had numerous publications. And I think that that's something that's quite commendable in terms of the contributions of the faculty members. Your last question is the most challenging question, and that is how to afford all of this, especially in programs perhaps where the incentive bonuses are coming straight out of the pockets of the surgeons from their billings. And that's why in the full-length manuscript, I added several paragraphs that Charlie Stoller first showed us and brought to our attention in a 2010 paper in the Journal of Pediatric Surgery about university pediatric surgeons benchmarking performance. And he really talked about how an active pediatric surgery service is an incredible moneymaker for the hospital. There is a tremendous amount of downstream revenue that we create. Without a pediatric surgery service, there's no ECMO, there's no level 1 trauma program. And he talked about case mix index and how the pediatric surgeons really enormously add to the case mix index of the hospital. So I think all of that can be utilized by groups to impress upon the hospital that we are bringing in an enormous amount of money for them. And I think it's quite understandable if they can help us at the end to achieve our academic aspirations by supplying some monetary input to the pediatric surgery service.
Well, that was spectacular. And I think that you're going to be getting some phone calls from folks around the country to ask you how to actually implement this. Fantastic.
Clearly a very thoughtful and provocative discussion. Thank you, Dr. Besner and Dr. Stylianos.
The final abstract in our session will be presented by Mr. Alex Sarosi, a medical student at the Icahn School of Medicine at Mount Sinai. His presentation is entitled Compassion Fatigue, Burnout, and Compassion Satisfaction in Pediatric Surgeons in the U.S.
Hi, I'm Alex Sarosi, and I'll be presenting today on compassion fatigue, burnout, and compassion satisfaction. Thank you to the research committee at APSA and those responsible for putting together this virtual meeting. Grateful to present our research for you today. We have no disclosures. Pediatric surgeons care for some of the sickest patients in the hospital, leaving them prone to the development of burnout. Nonetheless, previous literature has shown that they maintain high levels of career satisfaction. The phenomena of compassion fatigue and compassion satisfaction, on the other hand, have not been well studied. Compassion fatigue, or CF, is defined as secondary traumatic distress due to repeated ongoing exposure to patient suffering. Excessive compassion fatigue can lead to impaired physician empathy, which will inevitably hinder the patient-provider relationship. Burnout is defined as occupational distress with feelings of emotional exhaustion, depersonalization, and lack of personal achievement. While separate phenomena, CF and BO can result in similar long-term personal and professional issues, including decreased productivity and quality of care, medical errors, and even suicide. Compassion satisfaction is a potential mitigator of compassion fatigue and is the personal satisfaction and emotional fulfillment for providing care to others. It is typically enhanced by positive and professional experiences and job satisfaction. We explored the relationships between, attempted to identify potential predictors of, and compared the rates to other pediatric subspecialists of CF, BO, and CS in a national sample of pediatric surgeons. We used the Modified Compassion Fatigue and Satisfaction Self-Test for Helpers, or CFST, which is a validated instrument with individual subscales to measure the degree of each of the three phenomena, totaling 54 statements with associated Likert scales. Pertinent personal and professional demographic information was also queried, and the survey was distributed to the APSA membership in coordination with the APSA Wellness Task Force. This slide illustrates the subsets of the personal and professional characteristics of the study population. The majority of respondents were male, self-identified as white, worked at academic hospitals, and had 10 or more years of experience in practice, which reflect the APSA membership community at large. The analyzable response rate was 25.7%, which is similar to that of previous surveys distributed amongst APSA members. Here we present the predictors of CF, BO, and CS that were significant in the final hierarchical linear regression models. Prevalence of CF was 22%, BO 24%, and CS 22%, which is similar to what occurs in a host of other pediatric subspecialties, including intensive care, emergency medicine, palliative care, and neonatology. Our results did not yield a clear relationship between absolute compensation and risk of burnout. These results seem to argue that preventing burnout among pediatric surgeons will require more complex solutions rather than simply increasing monetary compensation or hiring additional partners to decrease the call burden. Most of the findings on multivariate analysis of compassion fatigue scores seem rather intuitive. For instance, most would expect higher BO scores in distress regarding clinical situations to be associated with higher CF scores. It's also not surprising that surgeons who talked with mental health providers about work-related distress have higher CF, as their CF is likely what is driving them to seek help. Our study also showed that those individuals with a history of serious surgery as a child had higher CF scores than their fellow surgeons. This finding seems to argue that some individuals carry with them non-modifiable predispositions to developing CF that may not be directly impacted by their work environment. An important takeaway is that CF, BO, and CS are distinct but interrelated phenomena. The interconnectedness is highlighted by the fact that experiencing extremes in one of these domains commonly impacts the other. It's therefore possible that creating a work environment that leads to improved CS among pediatric surgeons may simultaneously help to diminish BO among the same clinicians. Institutional organizational efforts should be aimed at all-encompassing goals, such as improving physician wellness, rather than attempting to address these domains individually. For example, providing outlets for physicians to talk about difficult clinical situations, such as through peer-based support systems, may simultaneously augment both phenomena. Thank you to the APSA Wellness Task Force and the APSA membership. This is our CFST and our contact information if you'd like to have more information about the study. Thank you very much.
Thank you, Mr. Sarosi. The invited discussant for this paper is Dr. Yu-Rung Hu from Lurie Children's Hospital at Northwestern University.
Congratulations on this important work. Burnout is really a major risk to our workforce, and I applaud all efforts to bring science to this conversation. The finding that really resonated with me is that it's not really about the money or even the workload. I'm one of the co-PIs for the second trial in which we study resident well-being, and it's been really clear that it's not just about duty hours or time off. I think your work really speaks to the fact that we're already very driven and resilient individuals as surgeons, and therefore institutions that focus their wellness efforts on individual skills like yoga and time management are sort of missing the mark. So we need to start thinking about this as a systems issue, and I am so glad that you have contributed to this evidence base. So that said, I'm particularly interested in your finding that the stress is due to co-workers. What is this? Do you have any further details? Is it misconduct? Is it just a failure of team cohesion? And how can we be better at supporting one another? Why aren't we good at that already? I also found it really intuitive and also fascinating that life partners are a major source of support. So what should we be giving them to avoid compassion fatigue and burnout?
I think that's a really important point. I think that, part of what this paper touched on was that compassion fatigue, burnout, and compassion satisfaction are really very interconnected, and you can't address one without addressing the other. So it's really a balance between them. So it's about addressing those systems. And one thing you brought up was about those peer-based support systems, which we found in other research work to be very effective at mitigating things like burnout and compassion fatigue. At Brigham Women's Hospital, as well as at Nationwide Children's, they've tried systems with peer-based support systems and seen that burnout has gone down dramatically. They haven't tested it as specifically with compassion fatigue, but I imagine the results are the same. And in our study, we saw that, as you mentioned, distress due to coworkers was a significant predictor of compassion fatigue. And we see that we didn't exactly ask, because one of the shortcomings of the study was that we didn't provide enough pretext for the respondents to share what exactly they meant. So this was just a bubble they filled out. So we assume distress with coworkers means either because of a medical situation they had with the patient, or just distress they had in the office, maybe not getting along well. But having those social support systems, whether they're at home or in the office at work, can be huge mitigators of compassion fatigue and burnout. The other question you asked about misconduct or mistreatment, again, we don't have specific information about that in terms of what they meant by distress due to coworkers, but we imagine it could be a significant factor. And to the question, what prevents us from providing each other with peer support? At the places I mentioned at Brigham and Nationwide Children's Hospital, where they tried to institute these peer support systems, they went through sort of rigorous training systems where they pulled out people who wanted to be a part of this peer support system, went through clinical training on how to do so, so that they were then prepared when people came forward with issues, whether they were contacted because they went through some sort of medical litigation, or they had some obvious distressor in the workplace, or they sought out help themselves. These people were trained to provide peer support. So it's not just that anyone can provide peer support, although we do see that life partners are a major source of support, probably because that person knows the individual so well and is already suited to provide that support.
Again, congrats on this work and thank you for contributing.
Certainly an interesting topic. Thank you both to Mr. Sarosi and Dr. Hu. This concludes our plenary session 2. We thank you for watching and thank all of our presenters and invited discussants.
Great. Thanks so much to all the speakers today and the commentators. What a lively group of discussants and just such activity in the chat room and in the Q&A. So we really encourage presenters especially to monitor that chat. It's very active, and please answer questions to those that are asking, both the chat and the Q&A, and you kind of need to toggle between both. So thankful to all of you.
Well, we're excited to have the Stryker presentation next on ICG. And I don't know how many people have gotten to use ICG and NERS in general, but it's really an exciting platform that is hopefully going to take our surgical visualization to the next level. And, lots of different companies organize or have produced these types of NERS systems. And so my hope is that we'll get a peek at one of them, and even in a little bit different application with pediatric cardiac surgery. So I have my popcorn here. I am ready. Hopefully I'll get a little bit better lunch, but I'm but hoping that this is going to be a great session by Stryker and how to potentially apply it to new and different things other than just cholecystectomy and some hepatic tumors. So think outside the box as we are looking at this, and I'm excited to see what comes up in the chat with all this stuff. You do need to click the next session button though, otherwise you'll be left just looking at the chat from before. So